Antepartum testing, assessment for risk factors, biophysical factors, psychological factors, demographic factors, environmental factors. The nurse's role in antepartum testing is to provide information about the test, to make them as comfortable as possible, to reassure them and their partner that it's safe and secure, and to help support them psychologically and document whatever response may be as a result of the test. Antepartum screenings or diagnostic tests are used to identify any anomalies, any disease, um, and they're offered to all pregnant women. Some of these tests include, especially something like an alpha-fetoprotein that needs to be investigated. If it's positive, it needs to be investigated a little further. But some of these screening tests are the amniotic fluid index, the biophysical profile, the contraction stress test, the daily fetal kick counts, the alpha-fetoprotein, or the triple marker or quad marker, the non-stress test, the ultrasound, the nuchal translucidity, the umbilical artery Doppler flow, and the vibroacoustic stimulation. Diagnostic tests would be considered the amniocentesis, the chorionic villus sampling, the magnetic resonance imaging, the percutaneous umbilical blood sampling, and ultrasonography. The fetal ultrasound imaging. It uses high-frequency waves to produce an image of an organ or a tissue. It's most common as a diagnostic during pregnancy. The ultrasound provides different services for different trimesters. Some of the things that it looks for is the presence of just the gestational sac to check the gestational age, for fetal growth, for fetal anatomy and presentation, for placental location, for fetal activity, number of fetuses, viability, amount of amniotic fluid, and to assist in an amniocentesis or chorionic villus sampling. So in the first trimester, the ultrasound is used to confirm that there's a pregnancy, to check that there's cardiac activity, to detect if there's more than one fetus, to assess for the visualization of the chorionic villus sampling, to assess for amnioticity and chorionicity of multiples, to evaluate the uterine structures to make sure that they don't have a bifurcated uterus or uterine trumps. Evaluate the cervix also, to detect if there's ectopic pregnancy or a missed abortion or a hiatiform mole, to evaluate any bleeding that there may be. In the second trimester, it's used to confirm the due date, to confirm cardiac activity, to confirm the number of fetuses in the position, to confirm placental location, to confirm the weight of the fetus and the gestational age, to detect for any anomalies. This is better after 18 weeks. Or to check for IUGR, visualize amniocentesis, evaluate the uterine and cervical structures, and any vaginal bleeding. In the third trimester, it's mainly used to check for the fetus presentation, for the placental location, used to assess in a biophysical profile, to check the amniotic fluid index, to perform a Doppler flow study, to evaluate the uterine cervical structures, to evaluate any bleeding, and any anomalies, and to check for IUGR. So a standardized ultrasound evaluates the fetus, the presentation, the amniotic fluid, the cardiac activity, the gestational age measurements, the number of fetuses, and the fetal anatomy. A specialized ultrasound is used to look at any anomaly that is suspected based on the fetal Doppler assessment or a biophysical profile or an amniotic fluid or fetal electrocardiogram. echocardiogram, or the measurements of any additional fetal structures. That would be like a level 2 or level 3 ultrasound where it's more detailed. Not 3D, not 4D. It's a different type of ultrasound. So there are the best time to do the first ultrasound is between 16 and 18 weeks of gestation. And when you want to do your third trimester, you want to do it 35, 36 weeks gestation. One of the ultrasounds that is first used is the transvaginal ultrasound, which is performed in the first trimester. It's to visualize just the fetus, and it's probably a very little fetus at this time, not enough to do any measurements at this time. These are when it's like 8, 12 weeks. You put your woman in lithotomy position, you get a sterile probe cover, and you just visualize the fetus through the vagina. The abdominal ultrasound, we need a full bladder. This is done, 16 to 18 weeks gestation, and you want to have the woman have a full bladder so that she can push the uterus up into the abdominal cavity by lifting it up when the bladder fills, taking it out of its pelvic cavity. And the woman is in supine position, and it's done externally through the abdomen. And we just move the transducer across the abdomen until we visualize the fetus. One of the advantages of a 3D or 4D ultrasound is that they can check for facial, cardiac, and skeletal anomalies. It's more detailed. With a MRI, what we're looking for is suspected brain anomalies. That's what it's most commonly used for. Rarely is it used for, but if we suspect a brain anomaly, that's what it's used for. The purpose is to see the tissues, the organs, the vascular structures that can be evaluated with the injected iodine. With the umbilical artery Doppler flow, we use advanced ultrasound technology to assess the resistance of the blood flow into the placenta. It gives us an idea if there are fetal reserves and adaptation in the placenta. It is directed to view the placenta and see the vascular channels increase in the afterload, and that leads to the fetal hypoxia. Chorionic villus sampling. With this study, you could also see if you have a fetus, the status of the IUGR. With the chorionic villus sampling, it is used to detect for fetal anomalies as early as 10 to 12 weeks. This is like if someone has a history of genetic disorders and want to find out early on if there is a problem, they would use this test. It's done before the regular ultrasound at 16 to 18 weeks. With your amniocentesis, this is a procedure that's done by inserting a needle through the abdomen to aspirate some amniotic fluid for genetic testing. The risk factors is that you could lose this baby because of the procedure. So there's always a risk factor for that. Usually we recommend this for women that are over 35 because they're advanced maternal age or have a history of genetic disorders or a positive alpha fetoprotein or any suspected hemolytic disease in the fetus. We usually do it between 15 and 20 weeks for genetic testing or anytime afterwards for any other complications that we might be assessing and that we need to take some fluid out. like to check for lung maturity, we can do an amniocentesis if the woman's not ruptured and she's in labor or whatever the condition is, or we might have to deliver the baby early. So to check the LS ratio in the amniotic fluid, we would do this test. It also detects infections. With an amniocentesis or a chorionic villus sampling, you would want to advise women that have had amniocentesis or chorionic villus sampling. You want to make sure you instruct them to report any pain, cramping, leaking, fluid, bleeding, decreased fetal movement, fever, chills to their provider. Once we do any invasive procedure with any of these women, you want to make sure that they get, if they are Rh negative, that they get administered RhoGAM. It's very important that if they are Rh negative, the woman is given RhoGAM after the procedure to prevent antibody formation in the Rh negative woman. With percutaneous umbilical blood sampling, this is when they take a sample of blood from the umbilical cord, and the blood is used to be tested for metabolic, hematological disorders, fetal infections, fetal karyotyping. So what we do is we usually perform it after 18 weeks gestation. It's more accurate that way. And based on the findings, the determination is taken. Remember, we are checking for any chromosome abnormality also. You're also testing for antigen, anti-1. You could all have beta, human chorionic, gonadotrophin, factors of 9 or 8C, or alpha fetal protein levels. Some of the conditions that is most common to look for with karyotyping is Down syndrome, trisomy 21 and 18, which are incompatible with life. Actually, 18 and 13 are incompatible with life. And also Patu syndrome, which is trisomy 13, and Edwards syndrome, which is trisomy 18, and Down syndrome is just trisomy 21. It also tests for Turner syndrome. With these women, you also want to give them the same advice as with the amniocentesis or chorionic villus sampling, to make sure that they report any signs of bleeding, cramping. If they do have cramping during the procedure, you can give them a little bit of terbutaline, and you would maintain them at least 2 hours after the procedure to make sure they are not contracting. So with maternal assays, it is used very commonly used to check for birth defects or genetic abnormalities. One of the most common ones that we test for with the maternal assay is alpha-fetoprotein, which is the glycoprotein produced by the fetal liver and the gastrointestinal tract and the yolk sac in early gestation. When the alpha-fetoprotein levels are high, we suspect that there is a neural tube defect or a ventral abdominal wall defect. That is about what 90% of it produces. And when the alpha-fetoprotein is low, it is also associated with trisomy 21, which is Down syndrome. So any of the two abnormalities would further instigate an investigation like an amniocentesis. When we do the alpha-fetoprotein is a blood test, and when we do have to give the results to the woman, we have to tell her that further evaluation is needed for a diagnostic of the condition that they might be suspected of having. With the triple marker screening, it combines all three chemical markers: the alpha-fetoprotein, the human chorionic gonadotropin, the estrol levels, with the maternal age to detect for some trisomies and neural tube defects. Like I said, 15, 16 weeks, this test can be done. Whenever you have low levels of alpha-fetoprotein with unconjugated estrol levels, it suggests there is a definite abnormality. When you have HCG and inhibit A levels that are twice as high in pregnancy, they're associated with trisomy 21. Decreased estrol levels are also an indicator of neural tube defect. There's a picture of how an amniocentesis would be done with ultrasound guide. Some other tests, antenatal surveillance tests that we can check for fetal well-being is the fetal movement count or the kick counts, the non-stress test, the vibroacoustic stimulation, the contraction stress test, the contraction stress test with a biophysical profile, or an amniotic fluid index. So the goal of the antepartum surveillance test is to prevent fetal death. So basically, we're monitoring the fetuses to make sure that they're are healthy as possible inside utero, especially if they have maternal morbidities like hypertension or diabetes that are very high risk to producing fetal any fetal complications, along with fetal death. So when we talk about fetal kick counts, um, usually when babies are healthy, they're moving around a lot. They have a particular time that they move around, and the mother usually tends to key in or hone in on these times. Their baby's either a morning baby or an afternoon baby or an evening baby where they just don't stop moving. When we start to notice a decrease in the baby's movement, it can potentially be that the baby's becoming hypoxic. It's probably one of the first signs that the babies are developing some kind of difficulty. They start to decrease their fetal movement. Kick counts, the purpose primarily is to make sure that they're well. We usually start educating women to do fetal kick counts after 28 weeks. However, some can start as early as 16 to 20 weeks if they start to feel movement, if they can identify them. Usually this happens with a multiparous woman who already knows what the kicks feel like. So the procedure is done that the woman is instructed to palpate her abdomen and track the fetal movement for about 1 to 2 hours. They're supposed to have 10 in a 2-hour period. Distinct movement. It doesn't mean that the baby switches from side to side. It means the baby pokes you with a hand, with an arm. You can either see it coming out of your abdomen or you can feel it. So if you use the 2 hours, it's 10 movements, distinct fetal movements. Is considered normal and reassuring. If you do the 1-hour approach, it's 4 movements in an hour. If you notice that there's decreased fetal movement, she's instructed to notify the provider and for further assessment. Probably they'll go into the hospital, get a non-stress test done, maybe even a biophysical profile. We teach these women to do this. We ask them to do it, to sit down for a period of 1 hour or 2 hours, or lay down and count these movements and to evaluate for fetal well-being. If they are to go into the hospital for a non-stress test, it is a screening tool that uses the fetal heart rate patterns to identify if there's any acceleration, and that's a sign of fetal well-being. What we look for is accelerations of the fetal heart rate, because normally when the fetus is well oxygenated and has an intact autonomic nervous system, he accelerates his heart rate related to movement. So this woman sits down and takes, it gets sits down or preferably lays down is preferable, not sitting down. We have done them sitting down, but it's usually laying down. And we hook them up to the monitor and we give them, like as you can see in that picture, and there's the monitor also, and we give them a little, oh my God, a connection that is connected to the machine to press the button. It's a pressing button and connection. And she is to press the button whenever she feels the baby move. Now, it doesn't matter whether she feels the baby or not to read the results, but it's a nice indication if we know when the baby's kicking or if she can feel it. So we usually start at 28 weeks to do these tests. The test is divided into periods of 20 minutes. In 20 minutes, the fetus is supposed to have 2 accelerations. An acceleration is classified by 15 beats per minute above the baseline that lasts a minimum of 15 seconds. And she's supposed to have 2 in 20 minutes. Now, if your woman does not have a reactive strip the first time, she will be sent to eat or walk, come back, and redo the test. We give her 15 minutes to get some food into her to see if that stimulates the baby, because sugar and we either give her juice. We could give her juice if we don't want her to move around because we're worried about the baby. And she, with the sugar, it accelerates the baby's metabolism. So they get this influx of sugar, whether it's from food, from the carbohydrates breaking down, or from orange juice, and they start to react. And they are given another test for 20 more minutes. So we give her like a 15 to 10 minute break, and then we do another test. And why is this important? This is important because babies sleep for 45 minutes. So if the baby's sleeping, he's not going to wake up. He's going to be sleeping. He's not going to accelerate his heart rate. When we sleep, our heart rate actually goes lower than normal, than our normal heart rate when we're walking around. So with 20 minutes of the test, 15 minutes of a break, and 20 more minutes of the next test, you're past the 45 minutes. So now your baby has to react or else we have a problem. So that's why you do 2 20-minute tests. If your fetus is less than 32 weeks, we're looking at a strip that instead of being 15 by 15 2 accelerations, it'll be 10 by 10 in 20 minutes. 10 by 10 meaning 10 beats above the baseline, lasting 10 seconds, 2 accelerations like that in 20 minutes. Why? Why is there a difference between 32 weeks or less or 32 weeks and above? Well, at 32 weeks or less, our central nervous system is a little immature. So we give the baby the benefit of the doubt of his immature system, and the most he can accelerate is 10 anyways, if he has a good heart rate. So this is why that classification is different. But if it's above 32 weeks, then we're looking at 15 by 15. With the vibroacoustic stimulation, it is used as a screening tool for auditory stimulation to assess fetal well-being with the electronic fetal monitor when a non-stress test is non-reactive. So I'll give you the scenario. The scenario is we've done our first 20 minutes. We had a non-reactive test, because non-stress tests, when they're not good, it's called non-reactive. When they are good, they meet criteria, they're called reactive, because the baby reacted to, accelerating his heart rate with his fetal movement. So now you're on your second test, and this is where the vibroacoustic stimulation comes in. And we are 5 minutes into this test. We had the woman walk, we had the woman eat. The baby should be super active because he's passing his 45 minutes or near his 45 minutes, and we see that this test is not reactive still. Maybe halfway through the test, we would do a vibroacoustic. And this would stimulate the auditory system of the fetus to react to the noise, as they so call it, to react to an artificial larynx. So this startles the baby and makes him move, because we put it wherever we feel the head is. When we do a Leopold's, we can feel the position of the baby, so we'll know where the head is. So when we activate this vibration in the fetus in utero, we do it by putting we used to have beepers before. Now you can have a tuning fork, or you could put your vibrating phone, and we put it near the head for 1 second while we're doing the non-stress test. And we can repeat 1-minute intervals up to 3 times. If nothing results, then we have to conclude the non-stress test is non-reactive. So before you do this procedure, because you are going to put something on her belly that's going to buzz or vibrate, you're going to tell her why you're doing this and explain to her that the non-stress test is not reactive, and we're trying to stimulate the auditory system of the baby and startle him to move so that we can see if he can have any accelerations. With the contraction stress test, it's exactly that. It's a contraction stress test. You have contractions. With a non-stress test, that means we have no contractions. With the contraction stress test, we have contractions. So the contraction stress test has also been called the oxytocin challenge test. It is a screening tool to see the ability of the fetus to maintain a normal heart rate in the response to uterine contractions or to labor, which is what uterine contractions are. And it's also used sometimes when we have a non-stress test that's non-reactive and we want to see if they would tolerate labor. So the purpose is to identify if your fetus is at risk for being compromised during delivery by observing the fetal pattern during the lack of blood flow to the placenta. So when you have a lack or a reduction of uteroplacental blood flow, which is associated with uterine contractions, we want to see how the baby reacts. So we do the same. We monitor for 20 minutes. And what we need from the woman is 3 contractions that are at least 40 seconds long in a strip of 10 minutes. So we can do this. So instead of going 20 minutes, we go 10 minutes with this one. We can do this by either giving her IV oxytocin, and as soon as we produce those 3 contractions, meeting the criteria of 40 seconds, we stop it. Or we can have her to do nipple stimulation by brushing her hand against her nipple for 10 minutes. That's why I said the test can take up to 20 minutes. And then the other 10 minutes should be the production of those 3 contractions. If it is a good test, it will be negative because it's negative of deceleration, particularly late decelerations during a contraction. If you have a positive test, it means it's associated with late decelerations more than 50% of the contractions that are produced. So you have 3 contractions, 2 of them will have a late decelerations at least. If we have a equivocal test or a suspicious test, it means that you had a variable deceleration or maybe 1 late deceleration, but it wasn't enough to consider it a positive test. So with a contraction stress test, we want a negative result with a non-stress test, we want a reactive result. So remember, reactive, the baby's reactive to movement. Contraction stress test is the baby is negative of decelerations. With your alpha amniotic fluid index, what we're looking for is we're measuring with the ultrasound the pockets of amniotic fluid in the 4 quadrants of the uterine cavity. The purpose is amniotic fluid reflects placental function and perfusion of the perfusion to the fetus and overall fetal condition as well. If we have a lack of amniotic fluid for the gestational age, we have oligohydramnios. If we have too much, we have polyhydramnios. But the purpose of the amniotic fluid is for the conditions inside utero. It helps, it shows about the fetus renal perfusion. It also identifies some fetal hypoxia if it's decreased. I don't know what. So, you know, in conjunction with using other tests like a non-stress test and an amniotic fluid index, you could have an accurate tool to assess for fetal hypoxia. So with a biophysical profile, it is an ultrasound assessment of the fetus status along with a non-stress test. So we use it to check the physiological parameters associated with fetal well-being, whether it's chronic or acute hypoxia. So the biophysical profile is approximately 30 minutes, and it uses 5 indicators, one of them being the non-stress test. Obviously, if we're doing a biophysical profile, unless it was ordered regardless of the results of a non-stress test, the non-stress test was the cause of the indication to have a biophysical profile. So what I mean by that, let me rephrase that because that was a little confusing. If the doctor orders a non-stress test and it's non-reactive, we're going to order a biophysical profile. We're going to call up the provider. We're going to tell them, hey, your non-stress test is non-reactive, after 40 minutes. Would you like a biophysical profile? Because that'll give us more information about the fetus. And the answer would be yes. Now, if the doctor says non-stress test and biophysical profile, then no matter what your non-stress test is, your biophysical profile will be done. Why is that important? Because if I'm doing a non-stress test with a biophysical profile because the doctor ordered it that way, I can get a 10 out of 10. This is how it's scored. But if I'm ordered a non-stress test and we end up giving a biophysical profile, we've got the most we can get to have a healthy baby is an 8 out of 10. So the biophysical profile tests for fetal breathing movement. It is looking for 1 episode or more of a 30 seconds of breathing movement that's rhythmic. It looks for fetal movement, 3 or more discrete body or limb movement within 30 minutes. It looks for fetal tone, where you have the fetal extremity extension and flexion within 1 or more within 30 minutes. And it looks at the amniotic fluid. Is there a pocket of amniotic fluid that measures at least 2 centimeters in 2 perpendicular planes? So those are the items that it's scored on. This is very simple scoring because it's either a 0 or a 2. A 2 meaning it's all perfect and a 0 meaning that it's all wrong. So the most you can get is a 10 or an 8 to be healthy, depending on how it was ordered. And of course, the lower the score, the more investigation that is needed. So if we have a score that is a 8 out of 10, that is reassuring, or a 10 out of 10, reassuring. If we have a score of a 6 out of 10, it's iffy. You should repeat the test within 12 to 24 hours. If we have a score of 4 out of 10, if that's non-reassuring, it warrants for further evaluation and even consider inducing this fetus or inducing this pregnancy. But if we have a 2 out of 10, it is immediate delivery because only one thing is working in that baby. So figure out which one it could be. It definitely is a sign of hypoxia and that there are no reserves. So we would deliver that baby immediately. So since I spoke about all this, and now I'm going to show you some strips so that you can identify what I'm talking about when we talk about reactive, non-reactive, positive, negative. So here we have on this slide the non-stress test. You're going to have the pressure transducer and you're going to have the ultrasound probe. Why is that important? The pressure transducer is what measures contractions. When we're going to have a non-stress test, what did I say? There are not supposed to be any contractions or else it changes the test. So that we're just monitoring that there is no contractions. With the ultrasound probe, we're monitoring for the fetal heart rate, and that is the line above and the block above on the paper, and the contractions are the block below the paper. They are separated by a space, as you can see. Each dark line is 1 minute. Each little block inside those dark lines is 10 seconds. So vertically, each block is 10 beats per minute. 10 beats. Okay. So usually the pressure transducer should stay between 5 and 10, and it's considered to be a normal pressure. This is reactivity. In order for the non-stress test to be considered reactive, it has to have 2 accelerations, as you can see on this strip. Those accelerations are actually 15 beats above the baseline. The baseline is the flattest line that has no contractions and has no accelerations or decelerations, and 15 seconds long. As you can see, they practically last, the first one lasts 2.5 blocks, which is 25 seconds. And the second acceleration has four little blocks in it. And they do go above baseline, as you can see, by 1, 2, 3, almost 4, 5 blocks in the first one, and about 1, 2, 3, 4 blocks in the second one. So they do meet the criteria of 2 accelerations in 20 minutes to be reactive. So this is a beautiful non-stress test. It is reactive. So in order to interpret the fetal heart rate tracing, you have to calculate a few things that you have to assess. You got to assess what is the baseline. That means which is the flattest line with no contractions that you assume it falls on one number. We used to do ranges, but now we do just one number. It could be the heart rate of the baby is 110 to 160, so it could be anywhere between 110 and 160 to be considered normal. So what is the baseline heart rate? Let's say it's 140. So then you have to go to 55 to be 15 beats up and go 15 seconds long to meet the criteria. So then you check is there variability? Variability is the squibbly lines that you'll see in the. I'll identify it in the next strip that we have. But variability is the squibbly line that looks like grass growing on a hill. It's in the flat line, but it's the movement in the flat line. Accelerations are, of course, any fetal heart rate that goes above the baseline that lasts at least 15 seconds, and 15 beats up is considered an acceleration. And you have to assess, are they periodic or episodic decelerations? Periodic means they happen with the contraction. Episodic means they happen at any time. So decelerations are any heart rate that falls below the baseline. So then you have to see the trend in the pattern. Is it going higher? If it's staying the same, is the heart rate staying at 140 or is it elevating? So you look at all these things. It's a little, we have a whole chapter on fetal heart rates. And then you check for the frequencies and the intensity of the contractions when you're assessing a tracing. And you measure those by frequency and duration and strength. So you see how that red line represents where the heart rate falls mainly, which is in the 150s. The squibbly line is the variability. This is a 2-minute strip, by the way. And it is within normal. And this is moderate variability. Okay, so variability falls into a few categories, 4 of them to be exact. Absent variability, think of it as asystole. It has no movement, no beat-to-beat variation. Minimal variability means that you have a minimum of a 5 beats per minute change or less. Moderate variability is when you have that grass growing on the hill. You see how it looks like grass that's just growing, just grass grows all different sizes. So that's when you have a 6 to 25 beats per minute changes in the baseline. And marked variability, think of it as VTAC. It's the one that has greater than 25 beats per minute, 25 beats per minute changes. But the problem is with VTAC, you can't assess, with marked variability, you can't assess a baseline because there is no flat line. It looks like VTAC. So why is variability important? Variability basically is important because when you have decreased variability, it is a sign of hypoxia. It is the first sign of hypoxia because what happens is you have a limited supply of oxygen to the peripheral tissue that can partially break down the sugars and convert them into lactic acid, which when the significant levels of acid raise in the bloodstream of the fetus, it's acidemia, which suppresses the central nervous system of the fetus and leads to cardiovascular collapse. That's why it's important. So here's a little picture about vibroacoustic stimulation, just a little review on everything that I talked about in the earlier slides. The procedure is to activate the artificial larynx on the maternal abdomen near the fetal head. You use it 1 second times 3 applications. It is to give a reaction to the non-stress test or not. So it would be classified along with the non-stress as reactive or non-reactive for successful or non-successful. The contraction stress test. Here's a beautiful strip for the contraction stress test. You see 3 contractions lasting more than 40 seconds and you have dips in that heart rate. In that fetal heart rate, there are dips. They're very subtle, but they are there. They are late decelerations, every single one. And you can see the variability is absent because usually absent variabilities with late deceleration signifies a category 3 fetal heart rate according to the NICHD, and it is classified as omnious, as a positive contraction stress test has an omnious pattern. The fetus is compromised. We need to deliver this fetus. So if this test is done by nipple stimulation, you cannot stop those contractions. You can hydrate her as much as possible, but her own oxytocin has taken over and has caused this to happen. It will go away when it decides to go away. You might end up in a C-section. But if this is induced by oxytocin, then we can shut off the oxytocin once we have those 3 contractions and we could flush it out of her system. It only has a half-life of 20 minutes, so we can correct this problem. But we do know that this baby has a positive contraction stress test and it cannot tolerate labor or oxytocin. So like I said, the biophysical profile, 8 out of 8. If we're not including the non-stress test, or 8 out of 10 if we are including the non-stress test. It's non-invasive. Here's the amniotic fluid index. They divide it up into 4 quadrants. There's your planes, and you look for 2 centimeters perpendicularly. Here's a beautiful pocket here that does reach 2 centimeters. The dark color is considered the pockets of amniotic fluid. And here is the description of the biophysical profile and the variables it assesses. Fetal breathing movement. You have to have 1 episode greater than 30 seconds during a 30-minute period. Will give you a 2. A fetal movement, 3 or more discrete limb or trunk movements in 30 minutes. The fetal tone, the presence of greater than 1 episode of an active extension or flexion of a limb within 30 minutes. Amniotic fluid that measures a pocket of 1 centimeter in each pocket, in 2, so it's a 2 centimeter total. And your non-stress test that has at least 2 accelerations within 20 minutes. That's a review of what we spoke about. Definitely, we're considering delivery, anything that's 4 or below. Whether we induce or whether we deliver via C-section is up to the provider. Like I said, amniotic fluid, anything below 5 cm is considered oligo. Anything above 2 cm of fluids is 22 cm of fluid is considered polyhydramnios. And it's a good indicator of fetal well-being. So any abnormal amniotic fluid index, you should report to the physician, whether it's greater or lower than the expected. Usually diabetic mothers have a greater AFI, and usually fetuses with renal problems have a low AFI. There's a nice picture of and here's a picture of, again, amniotic fluid, and also a fetal kick count chart that you can give the mother to monitor her baby. The end.